To sit down. If everyone can start making their way to their seats, is that working?
What did you do?
Test. I can't hear myself. But if everyone can start taking a seat and, as much as possible, sit up close to the activity and action here, that would be awesome. Thanks. If everyone could start sitting down, I'm going to kick it off here.
He placed me here, so that's why I'm sitting here.
Okay. I thought it was a special spot.
He told me to sit here. So.
Okay.
Wherever you want to sit. I just want to rob you down there.
Well, welcome. I think this is maybe the 7th or 8th kitchen table since I've been here at Premera that we've hosted out of the test kitchen. And it's a program that we started to really bring innovative thinking into Premera. And all year long, I've been really excited about the culmination of the year with a podcast in conjunction with GeekWire. And Premera and GeekWire, Premera is sponsoring a GeekWire Health Tech podcast that kicks off this year, or kicks off this month. And then this session that you're going to be able to watch tonight is one of the podcasts that will be posted on GeekWire. And we're really excited to have the panelists that we have, and Todd Bishop from GeekWire will do the introductions. And this is really there's so much happening, as we all know, about in health care and technology, and how those are technologies informing healthcare progression and the experience of the customer journey through healthcare system. And so we're going to hear from these amazing people about some of the work that they're doing in their companies. So I'm going to hand it off to Todd, and thank you all for coming.
All right, everybody, I'm going to sit down here. Welcome. So I'd like to turn it over first to ESPE. I'm sure all of you know Dr. John Espinola, MD. He is the Executive Vice President of Healthcare Services for Premera, and he wants to, he's going to be sort of setting the stage here for us as we then will transition into the podcast recording. So go ahead.
Thanks, Todd. So we're not recording now?
We are recording now, but
There we go.
yeah. So and move that mic really close to yourself.
Really close. Okay. Is this mic on?
Yep, you're good.
Okay, good. So thanks, Todd. I was just going to level set just so that we could put the comments that we're going to hear from our panelists in context. At Premera, we talk about what we do all day. We offer access to healthcare. The card in the pocket allows people to go get access to healthcare. The challenge we have is that we know that the healthcare that they get access to doesn't work as well as it could. And we simplify that by saying there are 4 things wrong with healthcare that could be better. The first is it costs too much for what you get. And that's because, too often, the second problem, you don't get the healthcare you need. The third problem, you sometimes get healthcare you don't need, and that's dangerous and unhealthy because nothing in healthcare is risk-free. And then the fourth problem is, along the way, you as a person don't have the experience you want or deserve. I'm pretty sure all of us have had this experience in one form or another and can relate to it personally. I can relate to it. Even though I'm a physician, I still have that experience, which is crazy. So if it doesn't work for me, it probably doesn't work for anybody else, because I should be able to make it work. I work at Premera, and I'm a physician. So we have a duty at Premera to make healthcare work better. That's our job. We give people access to healthcare, yet we give them access to something that's subpar. We have a moral and fiduciary obligation to do better. How do we do that? We do that through partnerships, because we know that within our 4 walls, we're not going to make healthcare work better. We're going to do it in partnership with those who may touch the moment of care. Decisions that lead up to that moment, decisions that occur in that moment. That's how we're going to make healthcare work better. So what I get excited about is talking to these folks here and hearing what they have to say and how they're going to help us bring solutions to bear that help us achieve our purpose. It's exciting. So as we've shifted our purpose, we have moved in a direction that forces us to work with those outside our 4 walls. Providers, innovators, entrepreneurs, all of these are going to help us move in the direction we need to make healthcare work better. An example on the provider side, which we won't hear about today, but is very important is what we're doing with our friends at Multicare in Tacoma, where we are in deep partnership, really sharing a business together with the single purpose of making healthcare work better. And we're doing that as an experiment for Pierce County. Many of the relationships that you're going to hear about today are experiments because we're bold enough to take the risk to try to do something that'll make a difference and learn from it and be better along the way. So I'm excited about today. Grateful to Todd and team for being here. Let's go.
All right, let's go. That's perfect words to kick it off. Thank you, Espy. That's great. And I'm told it's okay to call you Espy.
Amen.
That's right. Good. All right. So before we jump into the meat of it, if all of our podcast guests could scooch their mics up to the very edge and then scooch their chairs very close to the mics. And I'll introduce the panel. But first off, I'd just like to say a big welcome to everybody here. My name is Todd Bishop. I'm the editor and co-founder at GeekWire. And it is a real pleasure to be here. We are about to kick off the third season of our Health Tech podcast. And this has been one of the most highly listened to podcast series that we've ever launched. And we're very grateful and happy to be working with Premera on this and to have their support as the title sponsor of the third season of Health Tech. We've got lots of fantastic stories that we're going to be telling throughout the season. And really, I think today, the discussion with our panelists will in many ways set the stage for that entire season. So I'm grateful to Premera for the opportunity to be here to speak with you. And with that, I will introduce our panel. So first off, I'd like to give a big welcome to Ranjini Ramamurthy. She is a principal physician scientist at Microsoft with a background in both medicine and engineering. She's an MD and a computer scientist. She leads Empower MD in the Clinical Sensing and Analytics Group in Microsoft Healthcare, working on speech and natural language processing and developing an intelligent virtual assistant for physicians. So I will resist the urge to say Dr. Cortana. Is that right? Okay, all right. Aran Afek is CEO and co-founder at Vim. He leads the company's corporate strategy and business development, working to realize the company's vision of improving the overall value of healthcare. He's a serial startup founder with experience in sectors including telecom, gaming, real estate, and education. Welcome. Good.
Thank you very much.
And finally, Robbie Cape is CEO and co-founder of 98.6, a company that lets patients connect with doctors via secure messaging, offering a persistent virtual connection to healthcare, including diagnosis, treatment, prescriptions, labs, and consulting on health questions. Robbie had a successful 12-year career at Microsoft, and then he founded and led Cozy, a family collaboration and organizing startup, until its acquisition by Time in 2014. Robbie, it's great to have you on.
Thank you for having me.
Okay, so let's just do some quick intros of each of you. Can you give us each sort of your thumbnail sketch, your elevator pitch? If we were riding up the elevator at Columbia Center, Robbie, do you want to start it off? What would be your pitch on 98.6, what you do, and where you are in the process?
We are addressing the primary care crisis in the United States. On the one hand, we acknowledge that there's going to be a shortage of literally 20,000 physicians by the year 2020, and that number is going to rise to 30,000 by the year 2025. On the other hand, we all know here, especially, that primary care saves lives. In fact, if you introduce a single new primary care physician into a population of 10,000 people, you will reduce the mortality rate of that population by 5.3%. A single individual who has a relationship with a primary care physician is 5% less likely to be hospitalized. They are 6% less likely to end up in surgery, and they will save on the order of 30% on their healthcare costs over the course of their lives. So when we look at these two competing statistics, what we clearly see is that we have to introduce dramatically more primary care physicians into our ecosystem. And we're doing that with technology. So we are delivering an on-demand primary care service that is supported by artificial intelligence and deep learning that enables our physicians to treat on the order of 25,000 patients in their panel, and that number is just going up in an on-demand fashion wherever they are. So we meet people, they can be on the bus. Any of you could be sitting here today, download 98.6 and conduct a visit with a 98.6 physician, including our automated assistant. You could be standing in line at a grocery store and get primary care. And we deliver that care, the highest quality of care that is completely accessible at a ridiculously affordable price. So $20 for a consumer for unlimited access to primary care for an entire year. That's what we do in a nutshell.
Perfect. We just got to the top floor. That's great. All right, Ranjani, do you want to jump in here? Tell us more about your role at Microsoft, what the group that you're working with and leading is focusing on, and where you are right now.
That's great. Thank you.
Yep, and
I
lean right into that.
can you hear me?
Yep, just lean in as far as you can. Yep.
Okay,
Yep.
I'll do that. So I'm a part of Microsoft Healthcare as a part of the larger clinical sensing and analytics group. Within Microsoft Healthcare, we have two pillars, and I am super proud of being a part of the pillar where our primary focus is empowering those who are in the front lines of healthcare. So we think that building technologies that are frictionless, seamless, and amplify and assist those who already know what to do well. So we're not trying to replace any caregiver or any provider. We're just saying, let us help you, and let's do it in a way where it really provides value to you. Personally, I lead a team called Empower MD, where we're building an intelligent virtual assistant for physicians at point of care. So what this means is, all of you here know, physicians have a kind of a challenging, relationship with technology. And the biggest ask we've had has come from physicians who've wanted us to really leverage speech and natural language processing technologies to give them an intelligent scribe or a digital scribe at point of care. Of course, there are many things we could do, but we're trying to not boil the ocean. So that's the first project that I have taken on. I'm the lead on this project, and I've been leading that for about 20 months now.
That's great. And I know, as we were talking about previously, there's lots of privacy implications with that, and we want to get into that in just a little bit.
Sure.
Aran, do you want to give us a sense of what Vim does? I have to tell you, you're a little stealthy, Vim is. It's hard to find a lot of information on what you're doing. And my impression, at least from reading and watching, was that it's a little bit like an Apple Wallet for healthcare. You're bringing together lots of different services into a central place. Correct me on that and tell me what you're actually doing.
I think. Thank you. I think that the Apple comparison, I actually like it. I think what Apple brought to the world is, for the first time, a very integrated experience between software and hardware. So when I'm thinking about some of the partnership we're building with Permira in this market with leading high-value providers, the one who are really good in delivering, better healthcare at lower cost, more efficiency. I think about it like Apple, connecting the payer and the provider seamlessly, creating, liberation of data, seamless referrals, prior authorization, scheduling, those kind of things. So, most of it is not public on the website. I think it's kind of trying to focus more on the member experience, which is a good kind of byproduct of that, if everything is integrated. But to much extent, we are like to think about ourselves as kind of. I think Apple is a nice example. Thank you for.
Yeah, good. And by the way, you will at various moments witness moments where that will be edited out later, and this is one of them. The more you can talk straight into the mic, the better. The easier it's going to make it for me. Yeah, so it's good, perfect. All right, excellent. Okay, so so with that, at what stage of your evolution are you? Do you have products out in market that people are using now, or are you still in private beta? Where are you in the development of Vim?
Yeah, so we actually been very grateful to Permira. I mean, they found us almost 2 years ago working with large self-insured employers, and they said, "Hey, if you guys can help us to reduce unwanted variation, it's probably one of our biggest challenges by getting people to the right places." And we had a unique way of doing that with members, and Permira introduced the way to do it with providers and actually drive provider behavioral change and getting, the provider to partner with us to really drive the Permira members that see them to the right providers. And since then, we evolved, and we've partnered with multiple large payers that we're going to be announcing soon, and it's really started here in Mount Lake Terrace with the folks that's sitting here at the back and here the crowd, and yeah, it's been an amazing journey.
Oh, that's great. Okay. Well, you'll give us the scoop on that when it happens, right? Okay, good.
Correct.
Okay, good. So this is fascinating to me because we report on GeekWire all the time about technology companies going into healthcare, assuming that they know everything, right? I mean, tech companies, they rule the world. They're taking over. They're just going to conquer things. And inevitably, the stories that we end up telling are of the stumbles that they make. But here we have 3 technology companies in many ways that have figured it out, that are in the process of figuring it out. So here is my opening question for you, for all of you. If you could change one specific thing about modern healthcare right now, just one specific thing, especially when it relates to access to care, what would that be? What role would technology play, and how would the healthcare system need to change to make it happen? Who wants to jump in with that one first? Robbie, you're chomping at the bit, I can tell.
You always know that I'm happy to go first.
Yes.
So with all due respect, obviously to our hosts and to so many of the so much of the hard work that's happening in the healthcare space, the one change that we would make is to the underlying business model. We happen to believe that the faster we can move to a capitated model where the organizations who are delivering care are inherently responsible for the efficiency of the services that they deliver and for the health of their populations, the faster we will have the underlying incentives in order to make the necessary investments to deliver efficient care that results in healthier populations. We happen to believe that at the core of driving those efficiencies, obviously there's an enormous amount of work that has to happen to drive those efficiencies. Most of those efficiencies are driven in the delivery of care, we believe, and we believe that technology will have a dramatic impact on driving those efficiencies. The issue at hand is that in today's environment, in the fee-for-service environment, the drive to adopt those efficiencies, yes, there is drive, but the drive is not as strong as we believe it would be if we were in a pure capitated model. I don't mean a model that is capitated, built on top of chassis of fee-for-service, which we're starting to see with today's accountable care organizations. I mean a model that is purely capitated right down to the chassis.
Robbie, I want to make sure I'm understanding what you're saying. Are you saying essentially that everything should be subscription services? Is that if I could make a consumer analogy?
That's exactly what I'm saying.
Yeah. Okay. What will it take for that to happen? Because that clearly is not where we are right now.
As it turns out, the industry is moving in this direction, albeit slowly. Accountable care organizations are a move towards a capitated model. However, at least as we understand them, in most cases, they are still built on top of a chassis that is fee-for-service. Okay, which means that those incentives, it's all about driving incentives. And so in so much as you can drive those incentives, it's true that at an accountable care organization, the incentives are right to a certain depth within those organizations. But until you take it down to the lowest level of the care delivery, it's hard to imagine the sorts of evolution that would be required to drive the efficiency that we'd like to see occur in the industry.
Eran, do you just totally disagree with that? I can tell. I can see the look on your face.
So I really like that you said it, Robbie. I came from Israel 4 years ago. I moved to this country, and in Israel we have 3 large HMOs, very Kaiser much HMOs, and they're fully capitated. And I see how the Israeli healthcare system these days is trying to struggle with problems of access and physician burnouts, which we also experiencing here sometimes, but I think it's happening in larger scale there because of like them being underpaid. So I do see, while I do think that fee for service is evil and should be addressed, as Robbie alluded to, I do think there are many advantages to a private, competitive, a free market, even in healthcare, just because of the sheer value it brings to things like innovation and driving incentive to really push the envelope, right? I think right now, when it's just a wild west in terms of fee-for-service and very siloed organizations, I think it creates a huge problem that should be addressed. I think that the truth is somewhere between what Robbie said and where we are now, where perhaps the primary care workforce is capitated, and the rest of the ecosystem can still compete for the downstream cost. I think to your question regarding what's the single technology maybe change that can bring us there, perhaps is true data liberation on the payer side, on the provider side. I think the government, since I got here, introduced already 3 cycles of meaningful use. And those rules that, while trying to address data liberation on the provider side, haven't really done much meaningful things to, get this data in the hands of patients and payers. And I think if we could use that and get, very smart companies that probably some of them are headquartered here in Seattle, some of them are maybe in other places, to really dig in and do what Robbie said, and drive high value. Because what we're trying to do, and I think what you alluded to is, and capitation is also using data to render better care at lower cost. That's how you make money. And so this incentive would remain. I think data would enable that and make it more successful without going to too many details, which are boring.
As a layperson, I keep hearing the word capitation, and all I can think of is Game of Thrones. But maybe that's an appropriate analogy. I don't know. Ranjani, one of the reasons that it's so fascinating to have you up here is because you have been on both sides. You're an MD and you're a computer scientist, so you have a unique perspective on this world. I can't wait to hear the answer to your question. No pressure.
Thank you.
But what would you change if you could?
So I'm going to approach this from, I was a pretty recent graduate from the University of Washington, and I really go back to the quadruple aim and, take care of the providers so that they can take care of patients. That's what I'm super passionate about, and that's where I think technology can really help. And it's not about replacing the provider. It's not replacing the caregiver. My cell phone's never going to become my next physician. But it's about enabling them to really do what it is that they went into medicine for. They went in to take care of patients. Are there tasks that they do today that are time-consuming that we can take over? Can AI help in some way such that they practice to the top of their abilities and are not consumed by doing things that actually detract from it? All of these definitely factor into why there's a physician shortage, why there's burnout, et cetera, et cetera. And so that's what I think I would do. And how do you think, how would we go about that? And at Microsoft, what we're doing is doing this with partnerships. Really going in with healthcare systems or our other partners with an intention to first listen, to really listen to what it is, the problem that they're wanting us to solve, and partner together with a good dose of humility, in that partnership to say, okay, let's keep the end goal in sight. Let's see what we can do to make this happen, and in a very secure, compliant, and legal manner, and just going about that. So.
Okay, that's great. Oh, I thought you were going to jump in. Robbie, you had that look like you had something. So in each of these cases, it's almost a case study in the border of technology and humans, and AI is perhaps the biggest example. But I'm curious, where is the seam today between technology and humanity in the delivery of care, in access to care? And Robbie, I think you actually witnessed this because you see firsthand how amenable healthcare consumers are to using alternative forms of technology. what is the level of acceptance for non-human forms of interaction, of care? Where is that border today?
I'd like to share a couple of statistics first, which blew my mind away as I learned them, because we often get asked, are consumers ready for the digitization of care? 80% of humans, let's just talk about Americans, 80% of Americans begin each and every healthcare journey on google.com. Okay, 5%, 1 in every 20 searches that happens on Google is related to healthcare. 1 in 20. Just think about how many searches each of you did today. These are phenomenal statistics. What this tells us is that not only are people ready, but they're doing it. They're doing it. They are starting on Google. Who is our greatest competitor to fixing the healthcare system? It's Google search. Okay, and why are people going to Google search first? They're going because, one, it's in their pocket. They can go there when they're standing in line at the grocery store. Forget about what I said about 98.6 earlier. And guess what else? That visit to Google is free. Okay? It's very simple. People are quite predictable. When the technology is delivered to them and it's priced right and it's delivered in a way that delights them, they use it. We've seen this over and over and over again with technology that's been made available in the market and has changed the world. So we see this every day. We have tens and tens of people. I wish it was hundreds. I wish it was thousands. You know, we have to build awareness. That's a really hard thing for a young company to do. Our big issue is awareness. It is not willingness. When you put it in their pocket and you make the price right, and for us, you know, our perspective is, of course, you have to pay for the service, but the marginal cost of a single visit has to be zero. In other words, there is never a financial trade-off on the margin to check in with a doctor. And when you do that, you can focus on your health.
And that's the sort of the holy grail of the healthcare system, right? Preventative care, where you, at the very moment that you feel like something is wrong, or when you don't even know something's wrong, right? You're talking with a physician.
That's exactly right. We have a simple saying: the highest quality care is the care that is delivered early and often.
That's right. So, can an artificially intelligent agent deliver the care? Is that in our future? And I realize you're talking about an agent that's going to assist physicians, but if you look at big picture at the vision, is it possible that an AI agent will actually be making decisions that are today made by physicians?
It could be assisting physicians in making decisions. And I can give you an example of a use case that was done by Microsoft with Children's Mercy Hospital. It's called the CHAMPS program. So there are lots of babies, not lots, there are babies born with hypoplastic left heart syndrome. These are children who have very pressing medical needs and usually have to wait for a period of time before they get surgery. Now, with Children's Mercy, Microsoft had this project where they actually gave the patient's families a Surface tablet where they could actually log the children's vitals, the temperature as well as oxygen saturation, put this into the cloud so that their providers could be notified earlier on when the children were not thriving as they should. And they found this to be a huge success because in the past, what parents had to do was to take this big ring binder and document all this information and then call the nurse manager at the end of the week and give her the information. And then there would be some action taken on the numbers that were presented to her. But here, they actually found that they reduced admissions to the ER. And there's some amazing statistics of the number of lives saved. It's almost like a kindergarten class that they were able to save with just their first pilot. So of course, I do think that technology can help.
Okay, but not replace Augment.
Not replace,
Yeah.
augment. And we have other projects at Microsoft, like Project InnerEye, which is doing some assistive, productivity improvements for radiation oncologists as well. That, again, is a super interesting project where, when you go to a radiation oncologist, say you have prostate cancer, the radiation oncologist will spend about 40 minutes actually demarcating organs that should not be radiated, and using some artificial intelligence-based technologies. And this is out of Microsoft Research in Cambridge. They have actually brought that time down to 2 minutes because the system, sets this up for the radiologist so that the radiologist is then vetting what the system does. But again, the physician is always in control.
Okay. Around how much does AI play into your future plans, if at all? Does AI play a role in what Vim is doing?
I think that not too much these days.
Yeah.
I think we try to kind of connect the last mile, which is a lot of work with brick and mortar, a lot of work with the interaction of the patient at the point of care. I think there's obviously a lot of things that can be done to fix some of the engagement paradigm using AI, and I'll just give a few examples of some of the things we're working on. When I'm thinking about healthcare, I'm thinking about healthcare as like any other engagement paradigm that we're familiar with. So let's think about Uber and Amazon. So from a behavioral perspective, I like to think about it as a 2-axis diagram. On one axis, you look into the frequency of use. On the other axis, you have the ticket price. Uber is very high frequency, very low ticket price. Amazon, somehow high frequency, a bit kind of bigger ticket price depending on what you're buying. Healthcare is very high ticket price, low frequency engagement paradigm. And we see it in Silicon Valley a lot where there are many kind of well-funded company who are building, consumer engagement tools that has brilliant tech behind them, but lack the engagement of, and I think Robbie said, everyone's just going to Google. And I think the way to fix it will be using machine learning and AI to infer when would the member need me, instead of educating the member to go to my website when they need me. That's going to be really expensive. So instead, if we can infer when does the member need us by predicting or by ingesting real-time feed and understanding behavior, then I think we can more successfully engage in that journey. And that's just one of the things that we're working on at Vim that will maybe put us in that quartile of AI and machine learning.
The sort of applicability of machine learning and natural language processing, this whole field of artificial intelligence, really depends on which area or which sort of segment of healthcare you're thinking about. Obviously, the answer is very different when you're talking about primary care versus when you're talking about very complex chronic care issues or even just complex health issues, where as the truth is that the majority of the dollars are being spent there. On the primary care front, 80% of cases fall into 10 pretty straightforward categories of diagnoses in terms of what's coming in the front door. So it really is true that common problems are common. What that means is, that's exactly where AI tends to work really, really well. Now, you have to build a system that is capable of augmenting the physician, because in our current regulatory environment, and I think it's important for us to talk about regulatory in the context of all of this, in the current regulatory environment, you have to be a licensed physician in order to practice medicine. To deliver personalized advice of any kind to an individual in the United States, you need to have a medical license. And people are pushing those limits. I think that's a mistake. I believe that so long as that's what the regulation says, and I think that's what the regulation says for some very good reasons, we need to keep a physician behind every decision that gets made. In time, some of those regulations will change for very specific cases, like you could imagine for a flu diagnosis. You could imagine that in the next 5 or 8 years, there's a period of time where the flu is incredibly common. It's very well understood. We might be able to imagine in 5 or 8 years from now, the FDA approving an algorithm that is built on top of machine learning that is capable of diagnosing the flu and prescribing the right medication in the right circumstances. A case like that is possible, but that's one very, very simple case where you would have no physician present, and that's many, many years away. Right now, it's really about making the physician exceptionally efficient.
Yeah, that's great. Arun, you use the analogy of Uber and Lyft, and so I have to ask, so as we're talking about this, when I get into a Lyft, it is generally a driver that I have never met before, and I only know by his or her rating in the app. Is there a risk that we are going to be transactionalizing healthcare in the same way, and that we won't have the same relationship with our providers that we do today because we're merely taking the person who happens to open the door to the clinic that day, or answer, more appropriately perhaps, be on the other end of the chat, right? What is the risk to the relationship between the doctor and the patient in this new world?
I think there's a huge risk. The way I'm thinking about it is, so it's pretty easy to look into how millennials are accessing healthcare today. More retail clinics.
Yeah.
I think the Aetna CVS acquisition points to that kind of need to be in those retail clinics, urgent care centers that large hospital systems are popping up like mushrooms after rain. And I think it's gonna just continue and evolve because people just want to have access over a relationship. And I think the risk here is that a single time encounter might be good for certain people if they are very determined and they're very, I would say, kind of they're going to go and research everything and they're going to be smart. The majority of people still need guidance. And I think that's not going to change very fast. They need to have a trusted advisor that can lead them to the right place. I think me not having that kind of care champion, but kind of trusting on single time encounters can eventually lead to more fragmentation and more downstream cost that is going to be hard to prevent. So I do think there's a bit of a challenge in even an existing benefit design that doesn't mandate that I'll have a PCP. I think that's a bit of a problem.
So I'd like to just layer on top of what Arun just talked about. I could not agree more. And it's so interesting if you really look at the source. This is something that we study at 98.6 closely because we view our one of the jobs that we're doing is attempting to combat this regressive transactionalization of primary care. If you look at the causes of primary care, all of the examples that Arun listed, urgent care clinics, retail clinics, everything that's happening out there, I would even say old-fashioned telemedicine. These are not technology solutions, not even close. Technology is not behind any of those things. The underlying business model of fee for service is what we believe is leading to the transactionalization of primary care. If you look at those urgent care clinics that are popping up, why are they popping up? I mean, they're basically lead gen to higher cost services. I mean, talk about a transaction. Those retail clinics, I mean, we know why they exist and what they're trying to drive. They're trying to actually drive a secondary transaction. What we're trying to do at 98.6 is deliver good old-fashioned primary care that is at the underlying element a relationship between 98.6 and the patient. Because all of those benefits that we talked about earlier that happen between when a patient has a relationship with primary care, none of that accrues when that millennial is going into a retail clinic. That isn't a relationship with primary care. That's getting their problem covered. What we want to do, and this is a little controversial, and it's probably the hardest thing that we have to do at 98.6, but we're incredibly focused on it, is build a relationship between our patients and the 98.6 service. Not the physician who happens to be behind the delivery of care, but the service. The service knows them. The service understands them. The service knows why they came to the clinic the last time. The service is reaching out to them proactively to engage them in their health. The service understands who their family members are and what that might mean for their health moving forward. Technology can do that. And we actually believe that technology applied in that way actually leads to where we want care to be, which is it's about a relationship.
Ranjani, I can tell you really want to jump in here. Go
Yeah,
for it.
I wanted to jump in here. So I'm glad you took the conversation to that direction, because that's what I was thinking about in terms of how technology can be built to mirror some of the best practices that you see for care delivery. So let me give you an example. One of the best pediatricians I ever worked with in the Seattle area used to have a binder for every child, and he'd have the child draw a picture at every visit. So each time a patient, the child came in with her parents, even if it was a different provider, they'd pick up this book and say, hey, let me show you what you drew the last time around, and let's see what you can draw this time. So there was that personalization aspect that happened. So even if there was a change in the caregiver for the child, she saw that she was known to the physician. And that broke the ice. And so when I think of the technology that we build at Microsoft, I'm always thinking about how to personalize it for the patient as well as personalize it for the physician. So personalizing it for the patient in terms of what Robbie just said, knowing what the patient's social history is. If they have a dog called Gorky Poo, you should know that they had a dog called Gorky Poo, so that the next physician who comes in or the next nurse who comes in to provide the care is able to really talk about, it's important because there's enough research that shows that if the patient knows that they've made this connection with the provider, they are much more likely to actually generate a plan that they will actually adhere to, which, what are we trying to do all of this? At the end of the day, we really want good patient outcomes. So I love that you brought it to that point, because I think of it every day. How do you personalize it for the patient? How do you personalize it for the physician? And why can't we take the best practices we see in clinic and feed that into the technologies that we build?
Just one thing to add. I think this question really summarizes the entire discussion for me into so every primary care physician would be responsible over a year to run $10 million of downstream cost, right? Huge number, right? And just by the sheer way they would refer, they would decide whether to refer or insource their services, or they decide where to refer if they need to. And that's how we determine most of the downstream costs in healthcare, by where primary care people go telling you go. Then let's connect what Robbie said about Google. If 80% of the journey start in Google, right? As a patient, where am I gonna be more likely to land after that Google search? On the land page of a provider that charges $500 for an MRI, or the one who is able to charge $5,000 because they also have $100 million in marketing budget every year? The one who puts nice billboards over the 5i, or the one who is barely able to do a little Facebook page and close the month, right? And I think the more transactional in nature healthcare journey would be, the less involved the primary care physician would be and just act as a referral machine like the retail clinics are, not able to insource anything. They just refer out everything, right? And it's really easy to either open them or buy them, the more transactional it's gonna be, the more likely our patients are going to be acquired by providers who are able to acquire them through those channels. And the only way to, block this is building relationship with real people that give you real advice. And I know it sounds sometimes outdated in 2019. I mean, hey, can technology just do that? I mean, it can't. And so I think it's the ultimate way to kind of provide a good answer for this transactional nature that is driving a lot of downstream cost, which is uncontrollable.
I got to ask, and I know this is the question on the minds of almost everybody in this room here at Premera. What happens to insurance in this world? What happens to insurance if you're paying a subscription, if you're interacting over text? What happens?
So I can state just at the looking empirically at the center of many ACOs in this nation is our insurance companies. You still need to have a network of providers. The way you pay them has to be different. You might even have a network, multiple different health systems that could be involved in the ACO. There's a lot of administration, organization that still needs to happen. Even simply understanding, the underlying work, and we can talk about it in about a second here, but it takes incredible intellectual property to even just figure out what that capitated rate is supposed to be. Who's going to figure out what that capitated rate should be in a given location?
The monthly subscription fee.
That's right. That's right. As it turns out, hospitals are not well equipped to run those sorts of calculations. As I said, the underlying chassis that's in place right now is a fee-for-service chassis. So I believe, just like everything else that needs to happen to carry us forward, what ends up happening is this innovation comes out of collaboration amongst multiple key members of the ecosystem. I believe at the core, the beginning of a capitated model is going to come from a payer, a carrier collaborating with a health system or a set of health systems, and with a client being a self-insured employer. That is sort of the beginning of where the collaboration needs to happen. So I absolutely believe there's a critical role.
Anybody else want to take that question on? Yes, go ahead.
I think that the way I'm thinking about it is what's going to happen in the absence of a local market regulator like Premera. That's just the way I'm thinking about that. And I think the future I imagine is increasingly more aggressive provider consolidation. That without a regulator, and I'm talking about a private regulator that can interact and keep independents or groups in the game of being groups and not being part of a larger kind of more integrated system. So I think keeping those different parts apart is the most critical thing that we can have in healthcare. And the only body which is incentivized to keeping those things apart and capturing the premium and be the one who is able to drive reimbursement based on value is a payer. If we don't have the payer in the picture, like some parts of the Bay Area, for example, the provider is able to lock down population, increase the cost, and the absence of competition, they just gobble all the physician, capture the referral, just like gambling sites that will buy all their affiliates, so they can capture the different leads, and that's a huge risk.
Yeah. Do you have any thoughts on this one? No. Okay, it's all right. Okay, so one reason that it's been fascinating to watch Microsoft over the years is that Microsoft has gone through varying levels of engagement on healthcare. And one of the stories that I tracked personally very closely was Microsoft and GE with Caradigm, which ended up unraveling. And it's fascinating to me in part because currently we also then have another big Seattle area tech giant, Amazon, partnering with Berkshire Hathaway and JP Morgan in a very different way than Microsoft and GE did. I'm curious, I know you may want to recuse yourself from this, Ranjani, but I'm curious, what are the prospects for Amazon specifically making a serious change in healthcare beyond its own employees? Because that's what they're talking about first, is just working with their own employees. What are those prospects, Robbie?
I think Amazon is probably the single company in the world that is best positioned to have a deep impact on the industry as we know it today. And there are two specific areas. One that we haven't talked about at all, but I literally refer to our prescription crisis as an utter fiasco. If you dive into what's happening in prescriptions, we literally have for-profit organizations, I believe, and this is just my editorial, slightly over-dramatized view, almost stealing from consumers. It is the saddest state of affairs, and a huge percentage. I don't have the exact percentage on the tip of my tongue, although I wouldn't be surprised if someone in the audience does know what percent of healthcare spend is on prescriptions. Amazon is in the position, and in fact, I believe they've already started.
They've acquired PillPack.
They've acquired PillPack, and I think that is the tip of the iceberg to literally fixing the prescription problem in the United States and then around the world. And that will have an enormous impact, not just on access, but also on cost. And second step, I think also, this is speculation on my part, I believe that the next step related to cost savings and health is diagnostics. If you look at where I also believe that Amazon can have considerable impact, look at just one specific problem, the flu. The flu costs the United States $10 billion a year. One ailment. Amazon could, by virtue of operationalizing the distribution and the testing associated with the flu, and then operationalizing the delivery of the medication associated with the flu, they could likely cut out a material percent of that cost. Like, people literally would not need to leave their home to be tested for the flu and then to get their medication for the flu. And I'm just talking about one little issue. I mean, across those two areas, the impact could just be phenomenal.
What's, though, the risk of the crossover? Because I'm sitting here thinking, I could go to Amazon someday and it would say, you just purchased these bonbons. People who also purchased that also liked this Xanax. At what point, at what point does the line get crossed there with some of these tech giants? Sorry, maybe that's just a joke and we can leave it there.
We've built our platform at 98.6 on top of AWS. AWS is the leader in the industry in the area of both security and privacy. There's plenty of other tech giants, and we don't have to mention names, who've had their share of issues related to privacy and security, and we have yet to see that on the Amazon front. I think Amazon is doing a great job drawing the line. Why? Because Amazon puts only one entity first. Only one entity first.
At the expense of all others, Robbie, and that is?
The customer.
That's right.
That's
and
right.
It causes them all sorts of problems with everybody else, but that's a whole other issue.
Yep.
So do you Robbie? You sound like you're positioning yourself to get acquired. Almost, you're saying such nice things about Amazon.
Absolutely not.
Okay, absolutely not. For the
Absolutely
record,
not.
all right. Or does everybody else share that optimism about Amazon? Because I'm skeptical about them. I, in terms of their overall reach, I think they're trying to do too much. They're the everything. They're not just the everything store anymore. They're the everything. I coined that just now. All right, Arun, or Ranjani, what do you think about Amazon and their prospects?
When I saw that question that you sent on Tuesday, I was just thinking, I forget the exact phrase you used there. Could you jog my memory on that, please?
Okay. I didn't read the question.
I think it was something to do with. I actually would like to get the exact terminology in that question that you had.
I said And by the way, this is still extemporaneous, just for folks out there. We did sort of have some guidelines, so they knew at least what was coming, except for the jokes, obviously. What are the chances that Amazon, Berkshire Hathaway, and J.P. Morgan will spark meaningful change in the healthcare system beyond their own employee bases, and what
Yeah,
advice would you give them?
Yeah, and so I think, given that I'm working at Microsoft, what I'd say is, if they're going to be sparking meaningful change, I wish them well. And I think Microsoft wishes them well, even if they were a small company working on a super important problem that, and if someone can make meaningful change, I think we wish them well.
Okay, all right.
So I should just clarify, Todd.
Yes.
The work that they're doing in that joint venture, I think, is very different than the work that I was describing before. I believe that work that they're doing in the joint venture is primarily related to benefits.
Yes.
I believe I'm probably in good company in mentioning this here, sitting at Premera, that their objective is to, I'm going to use the big D word, to disrupt the insurance field, specifically around design and pricing of plans. And I think it's going to go much more slowly than anyone thinks it's going to go, is my perspective on that particular element, because what they're trying to do is very, very, very challenging.
Yeah. Do you want to jump in on this? Amazon, your thoughts?
Yeah, I think one of the most interesting things that Amazon actually invented in the past, but basically since the end of the 90s, is payments and pricing, and a way to efficiently price their inventory in a way that will drive more people to trust them that they are the most valuable place to buy things online, right? And maybe now also offline. And I think this is something that they will try to take to healthcare. TBD if they're gonna make it successful. But I think Amazon, if I had to bet, Amazon is gonna at some point try to perhaps acquire a TPA that will help them to price healthcare services to some extent. I think Amazon will look into see how they can pay for healthcare to some extent. Maybe it's gonna be more virtual services to begin with, and then maybe going into more physical services. And this is something I'm not completely excluding, and I think the industry should be keeping an eye open on.
Yeah, okay. Privacy, security, smartphones. We've seen smartphones do so many different things, from diagnosis to monitoring to communication. Where should the line be drawn? What are the limits today? And what will we see in 2-3 years in terms of healthcare delivery, access on our smartphones? Or is smartphones even the right thing to be talking about? Should I be talking about HoloLens or something like that, for example? Yeah, seriously, you can change a light bulb and be guided through an electrical system from somebody on a tablet via your HoloLens, so why not, something having to do with your healthcare?
So coming to your first question about mobile apps and how they could help, I would think that, in my opinion, using mobile apps to track and manage chronic disease conditions is definitely something that's happening right now. So long as they inform, and what I think about when I see this profusion of mobile apps that are targeted to the patients, I look at it in terms of, one, does it inform care that a physician gives, or is it just generating a lot of noise for the physician? And two, if it does inform care, how do you integrate it into the care delivery pipeline such that it actually betters outcomes for patients? So I think there's definitely a place for it. I've seen some very interesting ones. And again, some of them are really transferring some of the best practices from clinic into the app, and they're interesting, but I think with a grain of salt, and that it has to inform care.
Yeah, there was the really interesting startup out of the University of Washington by Shwetak Patel, Synosis, that got acquired by Google. It turned out to be Nest, we found out, but they were doing some fascinating things in terms of diagnosis, even replacing very high-end. approximating would be a better word, some very high-end diagnostic equipment. So clearly the power is there in terms of the smartphone, but where do you two see that going? Arun, smartphones in general, what will be their role in 2 to 3 years?
I think it's easy to look into other insurance industries, like car insurance industry, and how they're leveraging data from smartphones to give me feedback about how I drive, and perhaps also price my premium in accordance to the feedback I'm getting there. I'm sure that Jim Gratsko here is, heading actuarial science at Premera, would love to get feeds from mobile phones about my, heart rate, how many steps I'm doing every day, and perhaps look into maybe underwrite my premium in accordance and to create a differentiator. So I think, whether it's going to be on a mobile phone or other implants that I'm going to be wearing in the next 10 years, probably 3 years is still a mobile phone. I think this data is going to be invaluable and could be leveraged in healthcare.
So especially as a technology guy, I'd say my perspective on this is a little bit controversial. The data that is generated by these devices is complex. And at the end of the day, a lot of the data ends up implying what is essentially personalized healthcare advice to the individuals who are perceiving that data. And personalized healthcare advice is the definition of the practice of medicine. And you're supposed to have a license to practice medicine. So I think that when that data is being generated and is ultimately getting reviewed and understood and interpreted and counseled with the expertise of a board-certified physician, it's incredibly interesting. I mean, we're talking about taking diagnostic devices and essentially democratizing them and generating that data for doctors to understand. That is phenomenal. However, if you take that data and you kind of sort of, make your way around the rules and end up delivering advice without that license to practice medicine, I think you are ultimately playing with fire. You are yes, certainly in 40, 50, 60% of cases, you might be empowering people to have some insight that they might not have had before. But, it's not really any different than the democratization of healthcare information on Google. What you end up leading to is people who are not qualified to interpret that data are interpreting it and coming to conclusions about that data that they should not be coming to. And I think that's dangerous.
Did you want to jump in?
No, I guess I was just thinking it depends upon, I hear Robbie's point of view, and it just depends upon the kind of data that you're generating and what the application is for. If you're tracking your symptoms and trying to say, hey, what's a trigger for my migraine? That's a completely different thing, saying, hey, I should not be eating those chocolates. But a device trying to tell you that you're having a heart attack is a completely different ballgame.
Yeah, and the first one that really made it through this new FDA policy was essentially an EKG in your smartphone. Personally, I think that's kind of a little scary, and I'm a tech guy.
Right. And I was joking earlier about the Amazon connections, but there was the story this week about the woman who was still being advertised the baby products after the tragic death of her baby, and it was, you could see where, you could just envision where, writ large, if this gets extended to the healthcare system, all of this, that it could just go wrong. How do you avoid that from a privacy perspective?
Of all companies out there, Amazon's customer centricity, a problem like that occurring will send teams of people at Amazon scurrying to solve the problem.
And we should point out this one situation was it was Facebook and Xperia and others that were advertising to her. So we're nearing the end here of the discussion. I want to go back to the beginning because I asked you what you would fix. Big picture, if you, had the things fixed that you wanted to fix in the system, what would things look like in, what's the right time frame for healthcare? I would usually say 2 to 3 years, but I don't think that's realistic for this sector. Let's say 10 years. Can we go 10 years? What would things look like for the constituencies that you're serving? So Ranjani, for physicians or for consumers of healthcare, what does the world look like in 10 years if things change in the way that you hope they do?
In short, I'd say physicians would go back, or clinicians, any provider would go back to doing what it is that they know to do best, which is taking care of patients. And really, and I think that's just it. Just, taking care of patients, patient-centric care. That's why they went to medical school. That's why they went to nursing school. Let them do what they know to do best.
Yeah, Arun, how would the world, what would it look like?
I think as Robbie started, I think the business model would change significantly in the next 10 years. From a reimbursement perspective on the physician side, it's going to be much more value-driven. Not talking just about ACOs. I'm talking about large portions of the book of business going to be driven mainly by performance, which in my opinion will be a mixture between fee-for-service or enhanced fee-for-service with performance. And I think what we would start to see on the patient side is more personalized care plans from A to Z. So if I'm a diabetic patient, I would have a health plan for diabetic patients, right? And then I would have specific centers of excellence that would treat, my conditions. And I'm not going to just buy the same product that other people are doing. So I think there's going to be a way to differentiate and create very, very personalized insurance products.
Robbie, what's the world look like in your ideal world?
It's a combination of what's been already talked about. It's physicians who are practicing at the top of their license, who love their jobs day in and day out. It's patients who are getting what they need exactly when they need it. So what that translates into is, for the easy stuff, that technology is playing a very substantial role, and that there is this transparency across the system that enables those patients to, in the event that their care needs to get more complicated and hence more expensive, there's a transparency across the system that enables them to get that care in the place that's going to lead to the best outcome, where the quality is highest, and the delivery is the most affordable. Everyone will be happy.
That's great. That's awesome. I love your optimism. That's great. Well, a big thank you to each of our podcast guests, Ranjani Ramamurthy, Arun Efek, and Robbie Cape. Thank you very much for being with us.
Thank you.
Thank you.
And a big thanks to the team at Premera and also to ESPE for joining us earlier. Thanks, everybody. Go ahead.
Yeah, I just want to thank you very much. And that was amazing. It was awesome. And I really appreciate all of you coming out to Mountain Lake Terrace and spending time with us. And you each have a gift from Premera and the Test Kitchen. And thank you all for coming. There's still lots of food and drink, and so we have the room for a little bit longer. And this was awesome, you guys. Thank you. And Todd, when is this going to be posted? Roughly?
We'll let you know.
Okay.
We'll let you know, yeah.
So I'll let everyone know when it's posted. All right. Bye, guys.
That's all right.
Nice meeting you.
Thank you so much.
Thank you.